transplantations. So really, it's not particularly different. And I'll tell you in very, very simple terms, preventing an infection in anybody requires clean hands and nothing that is not clean to come anywhere near a patient. Right? So that means the entire environment, clean air, and also I personally like to keep my patients clean, so no polypharmacy to extent possible. So this is the key. Let's quickly go through the slides. Quickly close my slide. So the issue that one must need to think about is what kind of patients are we going to be dealing with. Next slide. So if you talk about stem cell transplant or solid organ transplant, the reason they are at particularly high risk for infection or bad outcomes, you should say they're not necessarily higher risk for infection, but a higher risk of very bad outcomes. So that's why we call them the sentinel chicken of the entire hospital. Because if you have a problem in your hospital's infection control system, the first place you're going to see it is in the immunocompromised patients, which are the transplanted, either solid organ or bone transplant. And the reason this is such a big problem is, unlike us, who have innate immunity, adaptive immunity, and therefore a little bit of time to actually manage the infection until a diagnosis or an antimicrobial is administered, the immunocompromised hosts do not have that kind of protection to rely upon. So the outcomes are really bad. Now, part of the complication also is that the treatment that we use for all of the transplantations very often abrogates the natural host defenses. Even in organ transplant, we are doing surgery, so we are creating a defect in natural barriers, and that allows a portal entry. There was a very nice study in AGIC quite some time back, and they actually looked at solid organ transplant and asked the question, is it the degree of immunosuppression that is the more important risk factor for bacteremias, or is it something else? And counterintuitively, it was not the degree of immunosuppression. The most important risk factors were actually invasive techniques, such as putting in lines or other drains or surgery. So really, this is something that we should understand. It is extremely important to limit the kinds of high-risk procedures that we are very fond of doing. I'll pick on my particular favorite, an arterial line. Why do you need an arterial line? Well, the anesthesiologists keep telling me, particularly in the ICU, that we need to monitor their blood pressure, we need to monitor their blood gases on the ventilator, blah, blah, blah. Look, in this day and age, we have a lot of non-invasive technology, and I will say this openly at the cost of probably offending some people. If you cannot manage a ventilator in this day and age with end-tidal CO2 and venous blood gases, you should go home. Next one. So the risk factors, it depends on the underlying disease, whether it is a hematologic disorder, or it is a conditioning regimen like chemotherapy radiation, or it is a complication like graft versus host disease, or it is the net immunosuppression. Net immunosuppression is a concept that Bob Rubin came up with. And what we said is that your total immunosuppression matters, because the immunosuppression that is contributed to by the underlying disorder, whether it's a hematologic disorder or a solid organ that has ended up in end organ disease, plus the iatrogenic immunosuppression, plus the immunosuppressive viruses, in particular CBD, or in the case of hematopoietic transplants, human technology. Blocking the right parvovirus B90. So the other thing that I've talked about, infected and breakdown, central lines or Maya reservoirs, graft versus host disease, skin or the gut, mucosal barriers. But most importantly, we need to think about disrupting the microbiome. And one of the things that we had a particularly bad time making people understand is that the anaerobes of the gut are your friend. They actually protect you. It is very rare to see a bacteremia with an anaerobe, even when severely neutrophil-imposed with cytotoxic therapy. In certain solid organ transplants, you can occasionally have a little bit of very operative trouble with anaerobes, such as liver or pancreas or small bowel transplant, which is why we cover anaerobes in those kinds of transplants. But other than that, anaerobes are your friends. So the narrower the spectrum of antimicrobial that you are going to use, the better off you are going to be. Understand that depending on what is happening, like total parenteral nutrition, other procedures, your risk of introducing a health-associated infection goes up very high, and a lot of these health-associated infections are antibiotic-resistant or multi-drug resistant. The other big problem, proton pump inhibitors. I just absolutely hate proton pump inhibitors. What most people don't realize is proton pump inhibitors are actually antimicrobials. They actually alter the microbiome of the gut. You will see a change in the various kinds of microorganisms that are present in the normal flora of the gut. Proton pump inhibitors actually increase the risk of increasing resistomes in the microbiome of the gut. Proton pump inhibitors also increase your susceptibility to foodborne pathogens by increasing the acid in the stomach. And there is no evidence whatsoever that it has any role in reducing the ulceration of the gut due to cytotoxic chemotherapy. That's not true. So the basics are very simple. Hand hygiene, screening if you are concerned about some high-risk pathogens that are multi-drug resistant. So very often, a lot of programs actually screen for MRSA, VRE, and CRE. Isolation is very, very important. We like to prevent them from getting into contact with other pathogens in the course of the treatment in the hospital. So very simple thing, particularly in bone marrow transplants or leukemias. Please remember there are visitors who are harboring respiratory pathogens and transmit them to the patient. So we try and reduce that risk by insisting on masking and plugging of anybody who's going in to see a patient. Perhaps it's also not a bad idea sometimes to give the patient a mask, particularly if you are not absolutely certain about the quality of ventilation. Environmental cleansing, this is a thing that unfortunately receives the least amount of attention, although I think that it is one of the most important things. Very often what I have found in some hospitals is that environmental cleansing is relegated to an outside contract. It's outsourced. These people are poorly trained, they have no idea what they are doing, and they end up doing all sorts of inadequate cleaning that really constitutes a great risk. Now the other problem on the other side is that people are using for environmental cleansing things that are completely inappropriate. For example, glutaraldehyde, very bad. There is a toxic substance that harms the patient, harms the other staff that come into contact with it, and it is not necessarily effective in environmental cleansing. Disinfection and sterilization, as long as they are done properly, and we heard a lot about how CSSV works and stuff. So, transplant specific, again, it depends on what kind of transplant you have. There are certain transplants who are particularly prone to bad quality air infections, and these are lung transplants or liver transplants and neutrophil deficient bone marrow transplants. Bad air, what do I mean by bad air? Bad air is inadequately circulated air. In the operating theater, we like 20 exchanges per hour, at least 3 of them from outside. In a bone marrow transplant unit, I would say at least a minimum of 12 with some exchanges from the outside. And if you want really clean air, you need to put an HEPA filter in place. The problem is HEPA filters, if not properly maintained, are completely ineffective. So ventilation is important for airborne respiratory infections. And in the past, it was believed that, well, the respiratory pathogens like RSV and human metapneumovirus, etc., are low morbidity, low mortality pathogens. That's not true. All viruses are bad in these patients. So one of the things that we tell our nurses, in particular in the bone marrow transplant unit, is to do is to screen who is going to do vaccination, whether it's a physician, a healthcare worker, or a dietitian, anyone. If they have anything to suggest that they might be harboring an infection, we try to eliminate them. If they are visitors, we ask them specifically if they have a respiratory tract problem, so a mask is required. Water management, clean water is very, very important. We have had multiple outbreaks of legionellosis because the shower heads were contaminated with protozoa that harbored legionella. Next slide. Next slide. Okay. Single use. I cannot emphasize this enough. I hope some of you had the opportunity to see my presentation yesterday that I was talking about toilets. I will tell you that as far as I'm concerned, for these very high risk immunosuppressed patients, it should be one toilet, one patient. And adequate cleansing of the toilet is imperative. People should understand that the moment you flush a toilet, you actually aerosolize a lot of stuff from the toilet that falls everywhere around the water closet in the toilet area. And that stuff can actually be contaminating the rest of the unit. So it's a very bad idea to not pay enough attention to adequate cleaning of the toilets. It's a very bad idea to have more than one patient using a toilet. So as far as I'm concerned, single room, single toilet, single patient. Sometimes it is necessary that we put patients on airborne and droplet or contact precautions in addition to the standard precautions. Now, when a transplant patient is going out for some diagnostic procedure, please give them a simple surgical mask to wear, and in some instances where the risk of airborne infections is high, like tuberculosis, COVID, chickenpox, measles, and an N95 mask. So we don't like our immunocompromised patients mingling a great deal where other patients sitting around and making noise, etc., etc. This is a particular problem in our patients who have diagnostic procedures such as imaging or any other endoscopy suite, etc. So proper planning of the patient pathways is extremely important. Next slide. Ventilation. We've already talked about this. I cannot emphasize this enough. I see a lot of hospitals that are very proud that they have air conditioning, this, that, and the other. And the moment I walk in, it smells bad. And we found this to our chagrin during the COVID pandemic, that despite the fact that everybody said, no, we have adequate exchanges of air and proper ventilation, when highly sensitive techniques were used to sample air in these hospitals, we detected COVID in the air. That meant that the ventilation was totally inadequate. This is an area that has received very little attention in hospital design and building, as how well they are ventilated. This is a design defect of hospitals. It is very difficult to compensate for that kind of design defect. You can try putting in HEPA filters. I will tell you that they are at best a compensation second best. Masks are a compensation second best. What we need to do is ensure that the building has been built properly, there's adequate ventilation, and we absolutely cannot have molds growing on the walls of the screen tiles. In the COVID pandemic, we saw a beautiful article that showed that post-COVID infection, people are immunocompromised, and they're at higher risk for mucormycosis and aspergillosis. Unfortunately, nobody really commented on why. I can tell you from my personal experience, it's bad air, contaminated air. There's mold growing on our dilapidated public health hospitals. There's aspergillus in there, there's mucor in there, there's alternaria in there, and there are a whole host of other pathogens, other molds that are what we call limitation fungi, very difficult to grow, very difficult to diagnose, and very difficult. Next. Whether or not laminar airflow actually adds to inadequate ventilation, there's uncertain. The data on it, the evidence on it is a little unclear as far as I'm concerned. Next slide, please. Next slide, please. Cleansing. All of the areas that house a patient who has a transplant have to be actively cleaned. Please do not use anything that aerosolizes dust. So vacuum cleaners, no. Usual broom for jhadu, no. You have to wet mop the patient. And nothing special is required. Actually, you have to make sure that you are doing that. If you are going to use a vacuum cleaner, you need to be critical. You cannot have water mix. Water is what allows for the molds. Molds are the highest mortality pathogens. Next slide. Hand washing. Enough said about this in our entire conference. But please remember adequate hand washing is of critical importance. Please remember that pathogens that are on the surface of your hand will penetrate a glove in exactly 30 minutes. So thinking that just because you've got gloves on, you're protecting the patient, no. You're not protecting yourself, you're not protecting the patient. You need to cleanse your hands, put on the gloves. After you're finished with the glove, please discard the glove and once again cleanse it. No jewelry on the hands. This is an absolute no-no. Next slide, please. Equipment. Again, proper cleansing of the equipment and proper disinfection where required. Again, is extremely important. Next slide. Plants. We do not like plants in areas where we are housing bone marrow transplants, particularly when they are neutropenic. This is known to be a source of very difficult to treat gram-negative organisms as well as antibiotics. Play areas, toys, same thing. Next slide. Healthcare workers need to be immunized and make sure that all of the healthcare workers who are going to be entering the care of these patients have all of their immunizations updated. And also, healthcare workers should be mindful that if they have any kind of respiratory tract infection, even if they think this is an allergen of an infection, it is best to try and not be involved in the care of that patient. It is critical when masks and gloves certainly should be done. Please remember that a lot of these so-called airborne pathogens like influenza, RSV, all of these viruses can also be transmitted in dirty hands. Prevent bacterial, intravascular, catheter-related infections. Again, the less we use catheters, the better off we are. Certain catheters that really can be avoided, like arterial lines, should certainly not be used. Arterial lines, very often I see them placed in people who are thrombocytopenic, and then they are given platelet transfusions. Look, platelet transfusions are a major cause of transfusion-associated lung injury. And then they are wondering what kind of bacteria or what kind of fungus is in the lung. I keep telling them, look, this is tragic. Firstly, you should not have put in the arterial line. Because you wanted to put in the arterial line, you gave that thrombocytopenic patient a lot of platelet transfusions. So, avoidable transfusions, remove them. Avoidable interventions like invasive catheters, avoid them. surveillance, routine surveillance of this, that, and the other by culturing this, that, and the other is really not particularly common. But if you suspect that there is something going on that you don't like, for example, the air vents look dirty, nothing wrong with training a culture to show people that they have not done a good job in cleaning the vents of the air conditioning system. If there is an outbreak and you think that part of the reason you're having an outbreak is inadequate thermal cleaning by the hospital staff, it's an excellent way to show by culturing all of the high-touch surfaces that they are housing pathogens, and there's no completely inadequate cleaning space in place. Remember that dirty air is frequently contaminated by spores of molds, so sometimes it becomes necessary to use an air sampler and actually culture it. Not an easy thing to do, you require a very skilled person to do it who really understands it. Finally, most importantly, keep the patient clean, which means unnecessary medication should be avoided. Avoid drug interactions. A lot of these patients are on multiple different drugs. Some of them are cytochrome P450 inducers or inhibitors. Therefore, a lot of drug interactions happen. These drug interactions look like infections. Anytime you think there is potentially an infection, please do a proper evaluation. I would strongly recommend that you call in an infectious disease clinician who has specialized interest or expertise in transplant to help you plan the evaluation, what kinds of tests to do, alert the microbiologist as to what to do. That gives you a much better way of diagnosing and managing infections in this very, very vulnerable population. I'm going to stop here so that I give you enough time to ask questions, and I'm happy to take questions. Thank you, sir. Thank you so much for this very good presentation. We have seen that many times our hospitals environmental cleaning has been compromised. If you see on the European countries, they always select a disinfectant based on their EPA authorization. But in our country, we don't have such those agencies who can register the particular disinfectant to be used for so and so organism. That means for our scenario, in Indian scenario, we can give this responsibility to the infection control committee to authorize a particular disinfectant for the use in the different areas in the hospital, like ICUs or operation rooms or your isolation rooms and all. So we have started disinfectant stewardship program in the hospital, where the selection of the disinfectant, appropriate selection, and also the appropriate duration of the disinfectant to be applied to the particular surface. Because many times we have seen that when they apply the disinfectant, it will get evaporated within a minute. And the manufacturer's recommendation, if you see, they say that it should be there at least for the 2 minutes. It should be wet. And also, there is also, sometimes we have seen that unless we have a close monitoring, hospital staffing are not covered all the surfaces while they are cleaning. So these are the aspects we have started as a part of disinfectant stewardship, where a selection of the right disinfectant for a right duration and the right monitoring when they are using the disinfectant in the hospital. Regarding the transplant patients, we have to keep the positive pressure room, but many of the hospitals doesn't have proper monitoring of ACH, air changes for our air velocity, even a particulate count, and many of them have a room which is said to be a positive, not having 2.5 Pascal differentiation from the adjacent corridor or the adjacent room, and many of them they don't have anteroom. Another major challenge we have seen in the hospital is that, as you said in your presentation, we need to have a dedicated equipment. This equipment shall not be shared with any other patient in the other room unless this is being discharged and it is being terminally cleaned. So the dedicated staff, dedicated equipment, and segregation of specially biomedical waste being generated from these patients in the other segregated area, not with other BMWs, for all the basic requirements, which I think has to be followed in the hospital. Thank you so much for this presentation. And now the forum is open for the questions. We have two speakers with us.
Comment. As you were also saying, disinfectants are very, very important. But as a microbiologist, I have seen in want of the disinfectant, they are forgetting basic cleaning with soap and water. If you are emphasizing more on soap and water, you can take care of so many infections. And then what is happening in long run, we are also going to see too much of resistance because of this disinfectant. We are not taking care. Thorough cleaning with soap and water, it should be quick and fast. You are pouring disinfectants, like as in public hospitals we are seeing they are using disinfectants carelessly without taking care there is dust in the ocean.
So let me give you a horror story. I've actually had to stop people taking a spray bottle and spraying glyceraldehyde all over. Right? Can you imagine that? And the problem that I have where all of you know, you say the ammonia compounds, that all of them actually are shown, there's clear evidence that to show that they increase the amount of bacterial resistance. So I discourage the use of quaternary ammonium compounds, quats. I discourage the use of anything other than soap water and alcohol. And alcohol, because it's expensive and difficult to use and also flammable, should be restricted to cleansing only very highly sensitive electronic equipment. For everything else, plain, simple soap water works. The key thing that you have emphasized is that the lack of understanding that organic debris if left behind will negate any kind of disinfection or any other process that you are going to use. So really what this means is you have to have a highly trained, highly motivated staff who are going to use a lot of energy scrubbing the place. Now there is of course a place for sodium hypochlorite sometimes, okay? Because particularly if you think that you are dealing with something like a norovirus or a C. difficile, where the toilets have to be disinfected with adequate amounts of freshly prepared higher concentration of sodium hypochlorite. Sodium hypochlorite is very pungent, very irritating. So the key thing is really, you want your housekeeping staff to do all of this for you. You don't want to pay them. You disrespect them. You don't know their name. You have no idea when they come, when they go. You have no idea that the housekeeper that was there on Monday is not the same housekeeper that you see on Wednesday. They don't have rubber galoshes. They don't have thick rubber gloves. They don't have a waterproof gown to do all of this work. How on earth are they going to protect our patients if we don't protect them?
Thank you, sir. The take-home message remains cleaning, cleaning, and cleaning. First of all,
that's why the first thing I tell people when I go in there is, listen, my evaluation of your hospital's infection prevention and control starts with a visit to your public toilets. Number one. Number two, I tell all of the nurses, if your house is clean and your hands are clean, I know your hearts are pure and my patient will be safe.